that, there are some other factors, including the solubility of the agent in the blood, the rate of blood flow through lungs and tissues, then what is going to be the partial pressure of your inhalation anesthetic agent in the arterial and in the mixed venous blood as well as in the tissue. So here you will understand that when your inhalation anesthetic is inhaled, first it will move into alveoli. Alveoli are covered with a capillary network, and then the inhalation anesthetic will move into the capillary network, and from the capillary it will move into the circulation, and from the circulation it will start moving into the brain. So what is important is the solubility of the agent in the blood. Not only that, but how much amount of your general anesthetic is moving into the tissues, that is through lungs and then finally into the brain tissue. And a major factor determining this is going to be a partial pressure. Partial pressure of the agent in the arterial and in the mixed venous blood as well as in the tissues. Ashutosh, have you muted yourself?
No, ma'am.
Please do that. Now, example is diethyl ether is highly soluble in the blood, and partial pressure of the gas control and its diffusion across the alveoli to the blood, and thus more of the diethyl ether concentration is always required to dissolve that diethyl ether into the blood, so that there will be increase in the partial pressure. So this is an example of how the solubility affects the attainment of the partial pressure. As we already know that diethyl ether being more soluble into the blood, it will take a longer time to reach to the desired partial pressure, and that gradient is required, that pressure gradient is required for any gas to move from one compartment to other compartment. For example, from the circulation to the brain tissue. And hence that is the reason why diethyl ether will take a longer time to induce anesthesia. Now moving to the next, general anesthetic. What are the different pharmacological effects? Anesthesia involves mainly three changes: unconsciousness, loss of response to the pain, and the loss of the motor reflexes. In high doses, all general anesthetics, they can lead to death, which I have already explained you when I explained you various phases of anesthesia. The major reason for the risk of death is that there can be a suppression of the medulla oblongata, and that is why cardiovascular center may get affected, blood pressure may drop down, cardiac arrest may take place, along with that even respiratory arrest take place, and that may sometimes lead to the death of the patient. So that is a very dangerous pharmacological effect occurring at a very high doses. General anesthetic at a cellular level, they affect synaptic transmission by causing decrease in the level of neurotransmitter rather than decreasing the rate of conduction of impulses through axon. And this is something all of you have to remember, because this is the point which differentiates local anesthetics from general anesthetic. General anesthetics are the drugs which are hampering synaptic connections between the neuron. It can be through various modes of action. They may inhibit the release of a neurotransmitter, or they may interfere with the plasticity between the synapses, but they are not interfering with the rate of conduction of the impulses. Local anesthetics interfere with rate of conduction of impulses. So this you need to understand, and no book will give you this information. This is an understanding point of view that what is a major difference occurring at a site of action of general anesthetic and local anesthetic. General anesthetics are interfering with synaptic transmission, and local anesthetics are interfering with the conduction of impulses. And that is why they are producing their effect locally, whereas general anesthetics are producing the effect on overall brain. Now moving to the next, that though we say that general anesthetic are affecting all the parts of the CNS, majorly the loss of our awareness or consciousness is because of the inhibition of a specific portion of the brain, and that is our reticular activating system, which maintains alertness. So there is a inhibition of a reticular formation, and whatever amnesia is there, of loss of the memory during the procedure or during the anesthesia is there, is because of the inhibitory effect on the hippocampus part of the brain. Almost most of the anesthetics, except ketamine, they produce similar neuropharmacological effects. They're different. The differences are only how quickly they achieve MAC concentration, that is minimum alveolar concentration, so their potency, how long the effect will be produced, duration of action, and what are going to be the different types of the toxicities, which organs are going to get affected, that will only differ. But mostly the neurophysiological effects remain same. Most anesthetic, except ketamine or certain opioids, they depress the cardiovascular system directly and sometimes indirectly via CNS. So you will see that there are many anesthetics which are having some arrhythmogenic effect. Like if you talk about halothane, it has an arrhythmogenic effect. It makes the patient susceptible to the arrhythmia induced by adrenaline. So these are some of the important pharmacological effects of the general anesthetics. Now, what are the different requirements of general anesthesia? When you are starting to give anesthesia to the patient, the first requirement is you have to prepare the patient for anesthesia, so pre-medication. Second, you have to induce anesthesia, and for that you need a mask or intubation. For either you can induce it by IV or some of the inhalation anesthetic, but most of the time induction is done by short-acting barbiturates, which are given intravenously. The next important thing is that, okay, fine, the anesthesia is induced, but the patient has to be maintained into the anesthesia for sufficient period. He should not come out of the anesthesia in between the surgical procedures. And therefore, this is a very crucial stage, that maintaining the patient for a desired period in anesthesia. So that's a maintenance. And very importantly is emergence, because if the patient doesn't emerge out of anesthesia after the surgical operations are done, there is always the risk of the cardiac depression, and the respiratory depression may cost the life of the patient. And even after the patient has safely come out of anesthesia, there are going to be a lot of complications while recovery or after recovery, and that may make the patient uncomfortable. We have to keep in mind that patient has undergone certain surgical interventions, and those minor complications may also prove to be dangerous to the patient, and that's the reason you have to do certain post-operative pain control, certain post-operative medications or post-anesthetic medication. So what are the different components of anesthesia is a pre-medication, the induction, then maintenance, then emergence, and administration of a post-anesthetic medication. So that entire process of the anesthesia takes place smoothly with a less trouble and less pain and less trauma to the patient. So first start with a pre-medication. Pre-medications are always, see, whenever there is any stress, the patient becomes anxious. Now he knows that he is undergoing some surgical operation, so obviously he will be anxious. So and because of the anxiety, there may be certain autonomic functions which may get disturbed. Certain physiological effects, blood pressure, heart rate may get increased, elevated. So what is the first thing we have to do is get the patient's anxiety back to the normal, and therefore certain anti-anxiety drugs are required to be administered, which include benzodiazepine, or we already know antihypertensive drug, clonidine, which is centrally acting drug, scopolamine, which is anticholinergic drug, and analgesic, centrally acting analgesic, or opioidal analgesic like morphine. Since you know that you have to conduct, while giving anesthesia, some intubation, you have to reduce secretions, you have to reduce vagal reflexes, and for that you have to take help of scopolamine, atropine, or glycopyrrolate. So vagal reflexes are usually prominent in small children, and they are also sometimes evoked by certain general anesthetic like halothane, certain pre-anesthetic medications like succinylcholine, or during intubation there may be certain reflexes which may get provoked, like during eye surgery, the vagal reflexes gets provoked. So to have anti-vagal activity, you have to take the help of anticholinergic drug. You have to sometimes give analgesics also prior to any painful stimuli. and not only before, but sometimes they are even effective after the surgery is completed. Now, what is this preemptive analgesia? The painful stimuli is set up, and that sets up the positive feedback mechanism in the spinal cord. There's a winding up mechanism, which usually accentuates the pain. The general anesthetics, they do not prevent wind up. So it is important that since general anesthetics are not able to do, you have to give some additional drug. So post-operative pain becomes troublesome, and then you have to administer certain NSAID, provided the minor surgery is there, or major surgery you have to give opioids, or sometimes even you have to give combination of opioids and local anesthetics, which can prevent this winding up mechanism. And therefore, usually after surgery, the painful stimuli perceived by the body is more intense than that of the normal. So to take care of that, you have to give certain analgesics, certain local anesthetics, depending upon the case to case. Post-operative anti-emesis is also required to be maintained. It is best to give towards end of the surgery rather than giving antiemetic before the surgery. The drugs which are preferred are always droperidol, metoclopramide, and so on. Now let us understand about second process, that is the induction. What are the different routes by which you can induce anesthesia? As I already told you, a very commonly used route is intravenous, because it is safe, it is pleasant, and it is rapid. Another route is administration or putting up the mask. But this is not usually preferred in adults. This is preferred in children which are below age of 10. And most of the inhalation agents are pungent and they may evoke coughing. And that's the reason it avoids the need to start an IV catheter before inducing any anesthesia. Patient may sometimes receive in children oral sedation for separation from their parents or the caregivers, because children don't like to move away from their parents. They get scared. So sometimes there may be oral sedation given, and then the other procedures may be carried out. And in case of patients who are totally uncooperative, you have to sometimes induce anesthesia by putting up the drug intramuscular. So there are three routes by which you can induce anesthesia. The one is intravenous, very commonly used, mask, which is very commonly used in children, and intramuscular, which is usually left as an option in uncooperative patients. Now let us understand to the types of general anesthetics. What are different types of general anesthetic? Now we can divide broadly general anesthetic into two categories. Those which are given by inhalation route and those which are given by intravenous route. Let us talk about the first, which are given by inhalation route. Inhalation route, we can administer the drug either in a gaseous form, or we can administer the drug in the form of a liquid, but we are expecting its inhalation, so that liquid has to be volatile in nature. The general anesthetic, which is gaseous in nature, is nitrous oxide. The general anesthetic, which is volatile in the nature, is ether, halothane, enflurane, isoflurane, desflurane, sevoflurane. The general anesthetics which are given by the intravenous route again can be classified into two categories depending upon their duration of action, and that is, first is inducing agent. That is, example is ultra short acting barbiturate like thiopental sodium or methotrexate. Then there is second category, which is a slower acting drug like benzodiazepine. Now ultra short acting barbiturate, although they are short acting, their onset of the action is rapid, and therefore they are the preferred drug as a inducing agent. Whereas benzodiazepine will not be a preferred because they are slow acting drug. And all benzodiazepines cannot be used. Diazepam is a preferred one because it also has anti-anxiety, skeletal muscle relaxant. So you get added effect other than as an inducing agent. And even the midazolam is a preferred one. The other drugs which are used not as anesthetic but are used along with anesthetic are opioidal, because opioidal drugs have a sedative effect also. They are morphine, fentanyl, sufentanil, and remifentanil. Other drugs which are used along with general anesthetic to aid their effect are propofol and etomidate. Whereas ketamine is a drug which is mainly used for inducing dissociative anesthesia. We will come to that when I will explain you what is dissociative anesthesia. And droperidol is a drug. Actually, a droperidol is a drug which is a neuroleptic drug, but it can be used to induce neuroleptoanesthesia. And that is why the anesthesia which is caused by these two drugs, ketamine and droperidol, are put into a separate category. The ketamine is put under the category of dissociative anesthesia, and a droperidol is put under the category of the neurolept anesthesia. So these are the various categories of the general anesthetics which are used. I hope the classification is clear. Now let us start about what are the properties of an ideal anesthetic. Depending upon who is using anesthesia. For patient, obviously it has to be pleasant, non-irritating. It should not cause nausea or the vomiting, and induction and recovery should be fast, and there should be minimum after effects. For the surgeon, if you see, it should provide adequate analgesia. There should be adequate immobility, complete muscle relaxation should be there. And even the surgeon will desire that it should be non-inflammable, non-explosive, so that there won't be much precautions required to be taken while giving anesthesia, and there will be cooperation of the patient also. And for anesthetics, its administration should be easy in the sense controllable and versatile. There should be a greater margin of the safety. There shouldn't be a sudden drop in the blood pressure. Even the vital organs like heart and the liver should not get much affected. Very importantly, it should be potent so that within a low concentration, the desired effect can be obtained and oxygenation of the patient will not suffer. Now, why oxygenation will not suffer? Because if you need to have a more amount of general anesthetic, your alveoli of the patient will be more filled with anesthesia and less with oxygen. So there are chances that there may be a hypoxic conditions. So if your drug is more potent, less amount of anesthesia is required and oxygenation of the alveoli is not getting affected. And very importantly, from the anesthetist as well as from patient point of view, that it should be cheap, it should be available at a lower cost, it should be stable, and you can easily store it. It should not react even with a rubber tubing or a soda lime. And that's a very important concern of an anesthetist when he is administering anesthesia. Let's talk about now the first category of the anesthetic, and that is inhalation agent or the inhalation general anesthetic. We have seen there are two broad categories. Those which are in gaseous state are nitrous oxide, and volatile agents include halothane, isoflurane, enflurane, and desflurane. So these are all volatile agents. Nitrous oxide is a gaseous in nature. Diethyl ether was used, but now it is banned. Anesthesia, this is anesthesia machine where you can see there are the gas and tank in which either you can fill your gas, or if there is a liquid, if there is a vaporizer, it will get vaporized, and then there is a reservoir bag. Then there is also a carbon dioxide absorber, and then there is a face mask which directly moves to the patient. So here the anesthesia which is vaporized will pass into through the intubation which is carried out into the body of the patient. So, and there is also pop-off valve is also there. So this is general idea. Nobody will ask you, but just to have an imagination that what all things are involved in administering general anesthesia, I am showing it to you. These are the pathways of the general anesthetic. When a patient inspires the gas and the mixture, there can be certain gases along with oxygen. There may be certain other anesthetic agent and your main anesthetic agent, which will move into the alveoli. From the alveoli, it will move into arterial blood. Once it moves into the arterial blood, there are three fates that it will get distributed into some peripheral tissues. Part of it will undergo metabolism, and then the remaining drug will move into the brain. After it has produced anesthesia, has reached equilibrium between the blood and the brain, and it been used by the brain, the pressure gradient, concentration gradient will reverse, and now the drug will start moving from the brain into the venous blood. After coming into the circulation, either it will move into the other tissues or it will move back into the lungs, alveoli, and will be exhaled out. So for inhalation anesthetic, it will follow this passage. So it is inspired, it moves into the upper airways, it moves then into the alveoli, then it moves via pulmonary membrane into the pulmonary blood, then it moves into the circulation, and I have shown you that it moves to the arterial blood. Arterial blood moves into the CNS, other tissues, or may get metabolized, the anesthetic which is there in the arterial blood. And then the reverse begins, that once the CNS has utilized the anesthesia, from there it will move back to the venous blood, back to the pulmonary blood, and the reverse will begin. Now we are talking about minimum alveolar concentration. I have also explained you minimum alveolar concentration in my previous lecture. But again, I will go to it because this terminology will come again and again when we will see individually each anesthetic. So it's a revision. It's the concentration, that is the percentage of the alveolar gas mixture that results into immobility without producing any noxious stimuli in 50% of our patient when they are exposed to a noxious stimuli such as surgical incision. It is almost analogous to our effective dose in 50% patient. Usually the MAC value ranges from 0.5 to 2 to produce adequate anesthesia. It is considered as a measure of the relative potency and even sometimes a standard for experimental studies. Now, anesthetic dosage are always expressed in multiples of MAC. For example, MAC value for different agents are additive, like 0.7. Suppose you are using a combination of nitrogen and halothane, then nitrogen MAC value is 0.7, halothane MAC value is 0.6. So whatever you are using a total mixture, it will have a MAC value of 1.3. Now sometimes the MAC value can exceed in percentage. I'm not talking in this magnitude, but it can, in percentage, it can exceed 100% also. And that indicates the potency, means that is a drug which is not very potent in the nature. So it can exceed 100% for weak anesthetics like nitrous oxide. So this is all related to the minimum alveolar concentration, which will give you an idea that why minimum alveolar concentration is important, because it gives us idea about the potency of the drug. It gives us an idea about how quickly the anesthesia, whether anesthesia is a weaker or a stronger. And it also gives us an idea about when we are going for a mixture of gases, what is going to be the final MAC value we are going to achieve with that anesthesia. And that's why you should know for the MAC value. Apart from that, for experimental studies, the MAC values can be used as a standard. The mechanism of action of inhaled anesthetics are, whereas local anesthetics are impairing the conduction of the nerve, general anesthetic have the effect on synaptic processing and they decrease the neuronal activity. The volatile anesthetics may block central nicotinic or cholinergic receptors, or sometimes they may block IHT3 receptors. They may activate certain 2-pore potassium channels that will lead to the hyperpolarization. They may produce their effect on cells of substantia gelatinosa of the spinal cord, which are very sensitive to the action of general anesthetic, where there are loss of senses. The stage of analgesia is majorly because of the effect on the cells of substantia gelatinosa. Now, which are the organs which get affected? The major two organs which get affected are cardiovascular system and respiratory system. Cardiovascular system, there is a lowering of blood pressure. Some of them also cause lowering of the cardiac output, and the lower peripheral resistance is also observed. Some of the general anesthetic, they sensitize the myocardium to the action of the catecholamines, and they are potentially sometimes dysarrhythmogenic and can cause ventricular dysarrhythmia. Very good example is nitrous oxide. Some general anesthetics affect respiratory tidal volume. They decrease respiratory tidal volume. They cause shallow breathing. They increase respiratory rate. They decrease overall minute respiration. They decrease ventilatory responses to the hypoxia, which may occur due to decrease in oxygen concentration in alveoli. Sometimes they decrease mucociliary functions, and that leads to the pooling of the mucus into the lungs. And that is why you have to give atropine, so that there won't be any secretion during the anesthesia, and blockade may not take place of the bronchioles or the bronchial tree. So there are various toxicities. Apart from pharmacological effects, we have seen different target organs which are getting affected with general anesthesia. Now we are looking at what are the possible toxicities with general anesthetic. Usually most of the general anesthetics, if you see, or fluorinated you see, they are undergoing certain metabolism, and they lead to the release of certain toxic metabolites which may affect the kidney, and that may cause nephrotoxicity. With the modern drugs, hepatotoxicity is not a big problem, but yes, with some older anesthetic, hepatotoxicity exists. Some halothane-like anesthetics are associated with malignant hyperthermia. Although it is not very common, it is rare, it is risky. So you should know that it is potentially fatal if it occurs. This is mainly a pharmacogenetic hypermetabolic state of a skeletal muscle, which is induced in certain susceptible individuals by inhalation anesthetic or succinylcholine, and sometimes it may be because of stress or exercise. It is a genetic susceptibility because there is a defect in the calcium channels, or there is a defect in the ryanodine receptors. What happens is that there is an excess of the calcium, which leads to the excess breakdown of the ATP molecules, that leads to the depletion of the ATP, accumulation of the lactate production, increased carbon dioxide production, myonecrosis, rhabdomyolysis, arrhythmia, and renal failure. Then how to treat it? You have learned a drug called dantrolene, which increases the reuptake of the calcium in sarcoplasmic reticulum. We can use this drug for treatment of this malignant hyperthermia.